is Christina Tupe. She was one of the residents at Maryland, then was one of my chiefs, and now is working at Baltimore Washington Medical Center. We're always trying to include a couple of the community docs because it's always different, I think, to practice in the big academic medical centers where we have every resource. I have the left atrial fellow, the right ventricular fellow, the left hand expert. But when you're out in the community, it's definitely a different world. So I think she's got a story about a massive GI bleed, and she wanted to talk about massive transfusion protocols. I got to turn you on.
Oh, hold on. Am I on now? Okay.
Yep.
All right. As Dr. Bond said, I'm Christy Tupe. I am, I guess, our community person, I guess. So if you are to pass out and drink too much of the happy hour, you will be taken to our community hospital. So, you know, ask us about our turkey Sammies. So this talk was really inspired about what one of my colleagues that saw a patient that had a massive upper GI bleed. And I was hearing the story, and I literally was getting Melena myself. So, hence the title, Doctors Without Melena Avoid an Ulcer When Managing a GI Bleed, okay? So this was a case, again, came to our community emergency department. It's a 58-year-old gentleman. He walked into the ER, actually came in, walked in with his wife somehow, some way, didn't take an ambulance, and triage nurse sees him and says, oh my God, and brings him right to a room. Wife was saying that he's got a history of cirrhosis. He has a history of known varices. He actually was banded like a week ago at one of the hospitals up the street, and they said he was vomiting blood at home. He's pale, he's encephalopathic, he's barely opening his eyes to a sternal rub. You throw him on the monitor, heart rate's 160, blood pressure in the 50s. You put on that pulse ox, and you know, it gives that really annoying thing where you can't actually read a pulse ox because their perfusion's so poor. That's him, right? So what do? We sign out, right? No, we're going to be talking about massive upper GI bleeds. So big things, we're going to be talking about the stuff that we do really well, which is resuscitating patients, right? This is when patients come, or if you're doing an in-flight emergency, right? What they want is they want an ER doctor, right? They want us, right? We're going to be taking care of this patient. We're going to talk about access, transfusing the patient, intubating them, medications, and then I can't talk about this without talking about the Blakemore tube. So what is a massive GI bleed? There's no real formal definition, but think about patients that are hemodynamically unstable, right? The person we described. They're tachycardic, they're hypotensive, poor perfusion, right? We put on that pulse ox, it's not even reading, their cap refill's poor, they're altered, they're rapidly bleeding. If they're literally sitting there with those like gross red, blue emesis basis, just like filling it up full of blood. Or right off the bat, are you transfusing them with more than 2 units of packed red blood cells? That's someone that's probably having a massive GI bleed. Something that also helps use the shock index. I think the trauma literature always talks about this, but something that I just don't naturally think about. But this is like math that I can do. Yeah, even our community ER doctors, we can do math, okay? Heart rate over systolic blood pressure. So in our patients, like 160 over 50, that's somewhere in the vicinity of greater than 1, right? So greater than 0.7 is going to be abnormal. And then greater than 1 is that when we're looking at a patient that would benefit from a massive transfusion protocol. So obviously, before we get into this patient, putting a plug, call your consultants early. You know, they got to get out of bed, they're not in the hospital, they have to decide whether or not they want to come in. So calling these people early and kind of waking them up a little bit is going to be important. So first, just talking about access, right? Everything that we're doing here, we can't take care of this patient if we don't get an IV in the patient, right? So short fat IVs, I don't do physics, but there's like Pousseau's law or something like that, you know, where, you know, something that has a bigger diameter, shorter length, you know, big fat, short IVs, cool. Pull the trigger on your IO if your peripheral IV fails. And I think that our EMS colleagues are great at this, and I think they talk about this a lot in the PEDS literature, right? Think of your attempts, 2 attempts, 3 attempts at a peripheral IV. I think we're a little bit worse at this. I think our EMS colleagues are like, let me put in that humeral IO, and we kind of are like, no, I think I can get it. 2 attempts, 3 attempts, whatever it is, then pull the trigger for IO. You can actually start resuscitating that patient. Knowing what you have in your emergency department. So I don't consider myself very old, but I've worked at a few different places. And how you resuscitate a patient, where you're going to find something, what you're going to put in that patient as far as access. Some places, maybe you work at shock trauma and you could put like a RIC line in everybody. Maybe, you know, I remember at one of the places I used to work, it was really easy to just get a Quinton dialysis catheter and place that in the patient to resuscitate them. So resuscitating them with a dialysis catheter. Where I work, you know, you probably get more Cordis. That would be the easier one to do. And then lastly, using pressure and limiting your tubing and caps. So this is a busy slide, not meant to be looked at, I'm sure, from far away in the glare, so you can't even see it anyway. But take something like an 8.5 French cordis. So we think our cordices, they're usually like 7 French, and the 8.5 is like the big boy. So if you look at this, flow rate under pressure, we're getting 600 mLs a minute. That's huge, right? But if we just put that to gravity, 130 mLs a minute. So if you do all this work and you're putting in this huge line to resuscitate the patient, you're like shooting yourself in the foot if you're not putting it on a rapid infuser or putting a pressure bag on it. Also, for peripheral IV, you take 16 gauge peripheral IV or triple lumen, TLC triple lumen catheter, and 16 gauge, right? It's the same thing, 16 gauge peripheral IV, 16 gauge in the triple lumen. It is the same size, but now we just changed the length, and we've almost cut our flow rates in half. And then just, again, my plug, I know it's at the bottom, you know, it's sexy to put in the cordis, but put in, you just humeral IO, tibial IO, these can be placed in less than 4 seconds on pretty much everybody, and you've already started your resuscitation. Another thing I just wanted to talk about was trying to limit your tubing and caps and things like that you're putting on the patient. We talked about how quickly we could flow that 16 gauge IV. Now we add some tubing onto that. We've now taken our time and increased it 1.5 times. Now we put on, you know, that little like catheter thing that goes at the end of the J loop. I was looking at like a lot of literature in the Europeans, they call it an IV bung. So if you put the IV bung, because I want to make that happen, we're going to start calling it the IV bung. So if you put that little IV bung thing, now you've tripled the time for it is to infuse something. So again, we've put in a cordis, we're awesome, we're high-fiving each other, we're resuscitating this patient. You put on this tubing, and then you put on that cap. Now it takes 3 times as long to infuse whatever you're doing. So whether that be blood, fluid, what have you. So you kind of just like, might as well put a tibial IO in, and you know, went with that. So moving on, I'm going to be talking about transfusion, and this is kind of where I wanted to spend a lot of my time in this talk, because I think it's something, you know, we do blood transfusions and transfusions a lot, but I think when we talk about, again, especially in the community setting, I don't work at shock trauma where maybe they're on the regular doing things like massive transfusion and massive transfusion protocols. So I think this is kind of a pretty interesting thing when you're kind of really doing this for real at the bedside by yourself. And again, I think we regularly transfuse patients, but for this patient that's coming in, I think a lot of the literature says, you know, give them blood. They're in hemorrhagic shock. They're bleeding blood. I think that's easier said than done. I don't work in a place where literally blood's just hanging around and you can just throw it right back into the patient's veins. So I think it's reasonable to give some patients some IV fluid. So 500 cc's, a liter. Again, I stick to like, you know, LR, plasma light. You don't want that hyperchloremic acidosis. Acidosis worsens coagulopathy. But I think it's reasonable to give them a little fluid, support their MAP while you're getting blood. And you're going to get some uncross-matched blood in the patient, 2 units, 4 units, and that's kind of how you're going to start your resuscitation. We're going to quickly just go, what kind of blood products, right? We got our packed red blood cells. Most people know this. The quick review, right? They're giving our O negative or O positive. So our O negative is going to be for our women of childbearing age and children less than 16. Men and women beyond childbearing age, they can just get O positive blood, and obviously it's going to be our volume, our oxygen carrying capacity. Our platelets, these are room temperature, kind of quickly can get them in, usually an apheresis 6-pack, served with a little bit of plasma in there as well. Fresh frozen plasma, this is going to be frozen, and we'll talk about that in a second. This is kind of, again, mostly our coagulation factors. Cryoprecipitate, mostly it's our fibrinogen, has some factors in it, has von Willebrand factor. And then lastly, I just want to quickly, PCC or prothrombin complex concentrate, not a blood product, but I kind of threw it in here. This has 3-factor and 4-factor PCC. I remember when I first started, this wasn't at a lot of hospitals. I think it's in a lot more places now. And the Europeans use this in a lot of their resuscitations when they talk about massive transfusion protocols and balanced transfusions, just because you can give it at room temperature, it doesn't need blood typing, and it's much smaller aliquots. So most of what we know about giving patients with GI bleeds blood transfusions come from the 2013 New England Journal study. They looked at restrictive versus liberal transfusion strategies, not recreating the wheel here, but they excluded patients that were having exsanguinating bleeds. So this kind of landmark standard of care study when we talk about GI bleeds and giving them blood transfusions, they've excluded the patient that we're talking about. So the study doesn't really help us much here. When we talk about massive transfusions, we're talking about essentially giving a patient a lot of blood. I don't want to remember all of this. I don't need to remember all of this, right? The first two definitions are like within 24 hours. So if you're resuscitating a patient in your emergency department for more than 24 hours, there's a lot of other issues going on there that I can't help you with. But these bottom two, greater than 4 units in an hour, or replacing their entire 50% of their blood volume in 3 hours. I've also seen 4 hours, but essentially you're just giving the patient a lot of packed red blood cells. If I had to write the definition, that's what I would write. Massive transfusion protocol, a little bit different now. This is the rapid administration of large amounts of blood products in fixed ratios, right, for this management of the hemorrhagic shock. So a lot of this comes from, when we talk about the proper trial, this was the 2015, this was looking at traumatic hemorrhagic shock patients, and they either resuscitated them with 1 to 1 to 1, so 1 platelet, 1 FFP, 1 packed red blood cell, or 1 to 1 to 2. And they found, and I know the literature is a little dicey, so I don't want to get too much into the studies and the weeds, but it was a non-inferiority trial, but again, found better hemostasis at 24 hours. So most people go to this 1 to 1 to 1 strategy for massive transfusion. So 1 packed red blood cell, 1 plasma, 1 FFP, this fixed low ratio balanced resuscitation. And with your blood bank, when you pull the trigger and do a massive transfusion protocol, this is essentially what they're mimicking. They're trying to mimic that 1 to 1 to 1. So indications for this, severe hypotension, someone with a brisk bleed, and you don't have guidance from labs. So if you're working in a place that has tags, that's like a point of care coagulation test, awesome for you. You probably don't need this. You can probably just really guide your resuscitation based on what the test tells you. For most of us, we're looking at things like INR and PTTs and some of these other things. So our labs are not really helping us as much when the patient's rapidly bleeding. So if the patient is severely hypotensive, they're bleeding in front of you, their shock index greater than 1 like we talked about, there's no response to that initial 4 units that you gave them we talked about, or you're giving them more than 4 units an hour of packed red blood cells, pulling that trigger for a massive transfusion protocol, which is that discussion with the blood bank. Some complications of this, because obviously, you can't just pull out a whole bunch of blood and give it to a patient without something happening, right? So hypothermia is going to be a huge one. So when we give patients blood in the emergency department, our nurses probably know this better, they get cold. So for every unit of packed red blood cells, you can drop their temperature 0.25 degrees Celsius. Not a big deal, right, when you're giving 1 unit of blood, right? You just give them a blanket, throw on a bear hunger, whatever. But now we're giving 4, 8, 10, 15, 16 units of blood or blood products. You're going to make them really cold really quickly. Around 35 degrees, we start having effects on our coagulation factors. 30 to 32 degrees, we start having this hyperfibrinolytic reaction. So you almost made your bleeding problem much, much worse just by not using a blood warmer, using a bear hugger, using blankets. Hypocalcemia, so in the blood there's citrate, and that can chelate or kind of bind up your calcium. Normally your liver deals with this, and this is not a big deal. That being said, in these kind of low flow states, your liver might not be working as well. So most massive transfusion protocols have ways of building in impure calcium administration. So for every round of that massive transfusion protocol, where maybe you gave 4 units of blood, 4 units of platelets, and 4 units of FFP, you're empirically giving the patient some calcium chloride or calcium gluconate. Hypokalemia, so if blood products sit along for a while, mostly the blood, you can get extra potassium that can leak out. Again, usually not a big deal, your body can handle that. But again, in these low flow states, maybe you're at risk for things like ATN, hyperkalemia can be an issue as well. And then lastly, transfusion reaction. So we can send people all the time for blood. You're going to have even more problems when instead of giving 1, now you're giving 15 units of uncross-matched blood. You're going to have much more issues. So trolley, taco, hemolytic reactions, allergic reactions, febrile reactions, all those things are going to be much more common here. So my practical thoughts. So who's done massive transfusion protocols in their hospital, pulled the trigger themselves? Okay, cool. So my thoughts, mobilizing this early, because when I've done it, you're like, okay, I need blood, and the patient's bleeding in front of you, right? You need it now. You have to mobilize this early. So again, I only experience in the community doing this. But you have to contact your blood bank. You need to send somebody. They got to run down there. They got to pick it up while the patient is still hemodynamically unstable in front of you. So mobilizing this early, pulling the trigger early if you're seeing that it's heading that direction. Aim for 1 to 1 to 1. I think a lot of obviously the studies are done in these like places where you have tons of people and tons of resources. And FFP is frozen. It can take 30 minutes to thaw. So and that's like 30 minutes that are really precious when the patient's really sick in front of you. So you're giving them blood. You're giving the platelets, which is nice because they're like room temperature. You can just throw those in. But then you're like waiting for your FFP to thaw. I wouldn't withhold blood products and hold packed red blood cells because I'm waiting for my FFP to thaw, right? So you're giving them the blood products that you need. You may have to play a little catch up later back, but trying to aim for this 1 to 1 to 1, but that might not be a realistic goal or realistic ratio for everybody in every community setting. And then something I didn't really think about, but it doesn't fix your baseline coagulopathies. You're thinking you're giving them all this FFP, you're gonna fix the fact that they're on Coumadin. No, this is basically a mass transfusion protocol mimics whole blood. It's not gonna fix the fact that the patient's on Coumadin or they're on Xarelto and they're on Pradaxa or some of these antiplatelet agents. You still have to give the reversal for that as well. And then lastly, monitoring these patients. Just like the trauma literature, we're aiming for permissive hypotension, so a map of like 55 to 60 or so. Again, if you're talking about something like a variceal bleed, those are venous bleeds, right? So we don't want to increase their central venous pressure, then we're all of a sudden putting a lot more pressure behind that venous bleed. And then things like arterial bleeds, you don't want to necessarily increase your shearing forces and then you disrupt that clot. Again, there's some parameters for the labs that you're shooting for, but again, these things are very much a moving target. So especially in the beginning, they're throwing up blood, they're vomiting blood, maybe they're having some melena, and then also you're giving them blood products. So a lot of these are moving targets, and sometimes even the literature, they says that it might take like 24 hours to some of these things to really equilibrate. You're checking the labs, but some of your labs are gonna kind of fall behind your resuscitation while you're doing it. Watching your ionized calcium, like I mentioned, and then monitoring for hypothermia. And once you've met these hemodynamic targets, right, their blood pressure is better, maybe they're mentating better, then we can move back to that restrictive strategy, right? The one that the hemoglobin of 7, monitoring for that. And you can terminate the massive transfusion protocol. Again, every blood bank's this different, so I don't want to speak too much about it, but if you have the cooler of blood and it's still there and you didn't mark anything, it's all still in the cooler, a lot of times you can return that to the blood bank within 60 minutes. So don't be afraid to pull the trigger if you have a patient that's really sick in front of you. A lot of times you can return that because I know that we all know what precious resource blood is. All right, so that was a whirlwind. We've now gotten access in our patient. We're giving them blood products. And now talking about intubation. I think this is kind of like pretty scary part in terms of intubation. A lot of people are like, oh my God, don't intubate this person, that's a variceal bleeder. But unfortunately, you don't really have a choice a lot of the times, right? If their mental status is poor, you might need to intubate them. Just kind of some general tips, resuscitate them first. I did not talk about this first thing in the lecture because we want to resuscitate this person first, right? We all of a sudden put them on positive pressure. Let's kind of go back to Lean's talk a little bit. All of a sudden you put them on positive pressure, it's a clean kill, right? We want to resuscitate them first so that we can actually take care of them. Personal protective equipment, unless you want to be walking around the emergency department in paper scrubs after you intubate this patient, wear goggles, wear a mask, wear gloves, wear a gown. This is the time to actually kind of dress up. Lower your induction dose, but not your paralytic. That's kind of in general shock management. Emptying the stomach, people talk about NG lavage. I think that if you think the patient's not going to throw up on you and cause more of a problem, it's one thing. It'll be nice to empty the stomach, and I think it'll be good for, obviously, afterwards when the patient's going to go to endoscopy. I'm not sure if it really buys you that much for the intubation. Limit your bagging. We don't want to insufflate the stomach. VL versus DL, or video laryngoscopy versus direct laryngoscopy. I'm sure plenty of people have thoughts on this. I think that obviously direct is great in the sense that we're not relying on a video, and a video very easily gets messed up with blood or vomit or whatever is in your airway. That being said, I know personally for myself with all this COVID that we've been intubating, I've been doing a lot of video laryngoscopy. I haven't done direct in a while. And this is the patient that we want to get this on the first attempt, right? So we're going to talk about something we can do in just a second for that. And then you may need your push dose pressors. I think there's a resident lecture that's going to be about this. So more on that if you want to know about push dose pressors. This is for Lean, like this is the extent of my animation creativity here. She had great stuff in her lecture. We want to intubate them with head up, okay? But if all of a sudden they start vomiting blood, we're going to drop the head of the bed. And that seems kind of almost counterintuitive, but we want to be able to get all that blood, all that vomit out and suck that out of the way so they don't aspirate on it. And lastly, the salad technique. I think it's been around a while, but something I don't think about as much. So you got your video laryngoscopy, you have that rigid suction catheter. You're almost like intubating with a rigid suction catheter, and that's going ahead of your camera, so you're not getting your camera all messed up from the blood and the vomit that's potentially in the airway. Suck that up, and then move that towards the left side of your hand. You're almost pinning that with your laryngoscope blade, and then you're going to intubate. All right, and then medications, I'm going to be kind of quick on this because, for the most part, they don't really help in terms of when we're talking about resuscitating this patient. Protonic pumps inhibitors, PPIs, going to help patients long-term that have peptic ulcer bleeding, so reduce the rate of rebleeding, need for surgery or need for repeat endoscopy, but only in patients with peptic ulcer disease, not in undifferentiated upper GI bleeds. But again, no mortality benefit here. I will put my plug. I think most of us have moved beyond the bolus and drip of protonics or PPIs, but I still see sometimes the hospitalists or things like that putting in there. The PPI bolus dosing, the BID dosing, is non-inferior to the bolus and the drip. So we save a huge access point with that by doing the bolus dosing. Octreotide, this is for our patients with variceal bleeds, can increase the rate of early endoscopy success, again, in these patients with variceal bleeds, but again, no mortality benefit. The only thing that has a mortality benefit is antibiotics. Lowers the infection rates of pneumonia, UTIs, SBPs, bacteremia, again, in patients that are having variceal bleeds. So, gold star, or only one. If you can only remember one medication, remember this one, okay? And then TXA, I only put this in here because with the CRASH 2 trial, they always talk about TXA in these patients with hemorrhagic shock. They actually had a trial, the HALT-IT trial, and it was a randomized control trial, multi-center, that looked at patients with acute upper GI bleeding, and they found no benefit on 5-day mortality and an increased rate of venous thromboembolism. So for the most part, keeping the TXA out of these patients. All right. Lastly, I cannot talk about massive upper GI bleeding without talking about the Blakemore. And I'm saying Blakemore, but I'm kind of using that interchangeable with Blakemore, Minnesota tube, whatever you have. Who has put in a Blakemore? I think two-ish, two and change hands. Okay. So not as common of a producer. We've had a few people that have done massive transfusion protocols, a little bit less in terms of the Blakemore. We can hear about your experiences in a little bit. I've done this once, but with the help of a friend at my prior institution. And just for anybody that doesn't know, Blakemore tube, it's got 3 ports on the end. The Minnesota has 4. Essentially, it's the same concept, and that's what I'm going with for concepts here. We've got a tube, and there's got an esophageal port and a gastric port, and one of them inflates your esophageal port, one inflates the gastric balloon, and then there's a way to aspirate. So this is kind of like a flimsy tube, and I didn't realize that until you actually hold this thing in your hand, because I think it's always in like a locked box somewhere, and then you're like, oh my god, I need the Blakemore tube. So you don't really get a chance to play with this thing and really see. It's super flimsy. You think it's like an NG tube? It's not. So then when you actually use it, you're like, you can't get this thing in. It's like super floppy. So sometimes you can also put it in some ice water beforehand while you're checking your balloons, kind of firm it up a little bit when you're doing it. And here's just a quick video kind of showing them place this Blakemore tube. Again, like I said, an ice water bath can help firm it up a little bit while you're trying to place it, and then you're going to pass it into the mouth. And you're going to bring it down to about 50 centimeters in depth. And then you're going to have a portable chest x-ray or portable x-ray, at the bedside where you can take a look and make sure that your balloon is below the diaphragm. So make sure that gastric balloon is below the diaphragm after you place 50 cc's of air in the gastric balloon. And there it shows that it's below the diaphragm, got 50 cc's of air in there. Now you can increase it to a total of 250 cc's, so additional 200 cc's of air. That's a lot, right? 250. And then you can see that fully inflated gastric balloon. And then they're going to start pulling tension and pulling it back. If you remember your anatomy from way ago, gastric varices sit right at that GE junction, right? So you're pulling that Blakemore tube and putting that balloon and tamponading those gastric varices. And then you'll tie it. You can use a 500 cc's or a liter bag just for kind of a counterweight on that as well. Now, for the most part, you're going to use the gastric balloon. If the patient stops bleeding with the gastric balloon, done and done. Awesome. You don't need to blow up the esophageal balloon. It's not, you don't always need that. So we put our air in their gastric balloon. Awesome, they stop bleeding. We're done. If we need to, we can also blow up the esophageal balloon. So if they're still in hemorrhagic shock, they're still bleeding, then we may need that esophageal balloon as well. And that's just 30 cc's of air in there. Again, if we can slowly start deflating that once the patient stops bleeding, then that's kind of the best of both worlds, kind of decreasing that risk of esophageal necrosis and perforation. And then we're gonna make sure that that stays in place. So kind of my final thoughts on this, call help early. This is gonna be a team sport. You know, you're gonna need your ICU colleagues, you're gonna need GI, maybe IR, maybe your general surgery. Short fat access, and make sure you're using pressure, transfusing these patients early, and then making sure you resuscitate these patients before you intubate. So that's all I had. If there's any questions. Oh, right in front. Yeah, I'll leave my email up there too.
That was a really great talk. Thank you so much. I have a question. Would you give K-Centra if you're also giving FFP? I just know that
No, yeah, so when they did it for the Europeans that have done this, and again, when I read a lot of it, I was like, the North American way of doing it is the one-to-one-to-one that we traditionally do, platelets, blood, and FFP. Some of the European centers, they use K-Centra, and I think they've had it a little bit more widely available than we had for more time. But yes, it would be used in lieu of FFP. So it's kind of just giving you your coagulation factors, but you wouldn't be using the two. They would be using that, blood, platelets, and then sometimes they would add on cryo as well for the fibrinogen.
Any other questions? I did notice when they were placed in the Blakemore, they weren't wearing any protective garb.
You know what? They wanted the paper scrubs.
Any questions? You got one more?
And I'm curious about the way that this runs in the community as well as in your trauma center. We see a lot of trauma, probably not as much as you do, but a good amount. And it's always heartbreaking when someone hemorrhages in front of you in an emergency department in 2022 in the United States. It feels like that's something that should never happen.
Yeah.
Do you pull blood before a patient gets there ever? Or do you do that when you have penetrating traumas? Or your medics carry it?
So our medics and our state police do, which has the helicopters. So for the bad transports, there's blood on the helicopters. And our shock trauma has a freezer of blood right there. So they have a couple of units before they can initiate the massive transfusion protocol. In the University of Maryland ED, we have to run upstairs to trauma and steal their blood and bring it back down.
Yeah, I think that's mostly most community places. I think pre-hospital might be.
I work critical access, and we had a time during COVID where we had 4 units in our whole hospital available. Luckily, no massive transfusion needed, but it's only a 20-bed hospital, so it's always available because it's the only thing that we have right there. So yeah, if EMS gives me any heads up about anything, I'll have them bring it down because they will take it back. Like you said, the cooler, we'll bring down the cooler, have it available, and then take it back. But luckily, I haven't had to deal with massive transfusion there yet because I don't know. I don't know how this would play out.
As I'm calling for the blood, if I was working where you work, I'd be calling for the helicopter too.
Yeah, exactly.
The helicopter better be spinning its blades.
Goes back to your call consultants early, call your transport early if in that case.
And then just for you to know, we have a couple of freestanding EDs in our state, and they all stock about 2 units of blood, just enough to have running as the ambulance is leaving. Dr. Leon.
First of all, I want to thank you for the talk, and I would like to put 2 comments. One of them, thank you for putting about the terminating MTP, because blood banks will continue making coolers of 661 until you explicitly call them and say, I am terminating MTP, because they will continue producing and thawing. FFP and putting up 6 units of blood and then preparing the 6 packets of platelets until you've officially terminated the process. And then the second comment is just prior to placing the Blakemore tube, just ensure which balloon is which. So, because
that's
even 50
definitely good.
cc's of air in the esophageal balloon could be devastating, especially someone who has esophageal varices.
Absolutely. Especially, again, a procedure that we don't always get to do very often, and something that we don't get to like just sit around and play with a lot of these Blakemore tubes or what have you. It does say it in like this tiny, tiny font, like gastric balloon and esophageal balloon, but I think especially in the moment when you're maybe a little hyped up and freaking out, hard to read that very small font, so.
Now I'm just curious though, how many coolers does the blood bank have? How many can they keep filling up? Like, can we get a whole train?
Probably hospital.
Any other last questions? Okay, thank you so much, Chrissy.
Thank you.